new computer, that's Rachel, the board, and then the video camera is another Rachel, Rachel Sonia. We're from the ETSU Dental Hygiene Clinic, and we really appreciate you guys letting us come and talk to you today. We just wanted to share a little bit with you today about oral health of the geriatric patients. Are most of you guys CNAs? Is that one of you guys? Yeah. I was actually a CNA before I went into dental hygiene, so nobody understands as hard as you guys work as I do. I worked in Bryan Center in Weber City for a while, so I know it is tough work. Probably the hardest work I've ever done. And I know when you're on the floor and you have so much to do, I know like the responsibilities of being a CNA, oral health kind of gets, just doesn't seem like at the forefront of importance because there's just so much other stuff going on. But we just want to talk to you a little bit today about some of the major issues of oral health with the geriatric patient. And the first thing I'm going to talk to you guys about is a condition called xerostomia. And there's a couple brochures here, and I'll pass all these out so you guys can kind of follow along with me. The first thing I'm going to talk about is xerostomia, and honestly, xerostomia is just a really fancy term for dryness of the mouth, and that's just when, right now my mouth's really dry, so I'm nervous, but xerostomia is just a fancy term for your mouth being really dry. And functions of saliva, the saliva in our mouth is there for a reason. And it's to moisten and cleanse the mouth, and to digest food, and it prevents infection by controlling bacteria and fungi. The saliva in our mouth really plays an important role in keeping the bacteria that causes cavities kind of in constant motion to where you're swallowing a lot of it. And your saliva acts to kind of clean your teeth. It's like a self-cleansing mechanism. It kind of cleans your teeth for you. And when people don't have a lot of saliva, and we'll go over some of the causes of xerostomia in a little bit, they don't have that self-cleansing mechanism. So that bacteria just stays there and it decays their teeth. And I know probably a lot of people here have dentures probably while you're at the yeah. But the ones that don't, a lot of the times, probably xerostomia is probably the biggest oral health problem I see with older patients. It's huge, and we'll talk about what causes it in just a second. Over 500 medications cause xerostomia as a side effect, and that's a lot. Most of the people we see in our clinic, most of the older patients we see in our clinic, are on some sort of medication that has xerostomia as a side effect, and it really does affect a lot of people. And we'll go over some of the major medications that cause it here in a second. There's also a syndrome called Sjogren's syndrome, and it's where your body attacks its own exocrine glands. And what happens there is your body attacks, it's an autoimmune disease, and your body attacks your salivary glands and it causes you to quit producing saliva. But that's a syndrome itself. And then HIV and AIDS, Alzheimer's disease can actually cause dry mouth, diabetes, anemia, high blood pressure, rheumatoid arthritis, stroke, head and neck radiation, nerve damage, dehydration, and smoking. So I know the nursing home I worked at, probably, I would say probably 90% of the patients that I saw had one of these. Either had a stroke or had some type 2 diabetes most of the time, or had dementia or Alzheimer's disease. And they probably, especially patients with dementia or Alzheimer's disease, they won't know that their mouth's dry. And we'll talk about some signs that you can look for. Because it's an uncomfortable disease. I mean, xerostomia is a big problem because it affects your tissues in your mouth. Even if they're wearing dentures, it affects their tongue, their ability to talk, their ability to swallow. And we'll talk about some ways that we can help our patients with dry mouth. this is just a partial, this is a partial list. Because like I said, there's over 500 medications that cause xerostomia. And these are the major classes of drugs, and you'll probably recognize some of these that I'm about to list. The first major classification of drugs that affects saliva, flow saliva in the mouth, are anticholinergics, and some example of this would be Benadryl or Spiriva or Dramamine. And then the next would be antihistamines, and that would be like Clarinex or Allegra or Zyrtec. And then antihypertensives, which are for high blood pressure, and that would be Procardia, Lasix. And then anti-anxiety medicine would be like Wellbutrin, Xanax, or Lunesta. And anticonvulsants, some examples of that would be Dilantin or Tegretol. And some diuretics would be Lopressor. And some narcotics would be codeine or Vicodin. And some antidepressants that cause dry mouth are Prozac, Lexapro, and Zoloft. And you probably know at least one patient that's taking at least one of these right off, if you could think of anybody. And there's a ton more. Those are just like the major ones that cause dry mouth. This is what xerostomia looks like. Literally, it looks as uncomfortable as it is. The tongue and the lips and the inside of the cheeks are going to be really, really red. And you've probably been able to tell patients that have really drawn out. And, you know, a lot of times, a lot of patients will sip on water a lot, and that helps. Some symptoms that you can look for are frequent thirst, red mouth, cracked lips, cracked tongue, like the picture up top there, and sores in the mouth, and a burning or tingling sensation. They'll feel their tongue will feel like it's burning. A sticky feeling in the mouth, bad breath, and problems with speaking or swallowing. And if xerostomia is untreated or they don't they just ignore it. Stuff that it can lead to is gingivitis, tooth decay. We talked about how you don't have that saliva in your mouth with clean your teeth off. That bacteria, the bacteria will stay there. Candidiasis, which is a fungal infection, and my friend Rachel back there will talk about that in just a second. You'll see that a lot with injured patients. And difficulty in denture wear. If they can't keep their dentures in, this is one, a lot of times a really good reason. Saliva acts as kind of like a suction for the denture, and if it's not there, the denture won't stay. So a lot of times it will affect, you know, they'll eventually stop wearing their dentures, so then their diet will have to change. And then you just come into all other kinds of problems. Some treatment for xerostomia would be saliva replacement therapy. And you can stimulate the salivary glands in your mouth by giving them sugarless gum, just to make sure it's sugar-free. Because the goal here is we need saliva to prevent cavities, so we want to give them sugar-free gum. And sugarless candies such as Crystal Light, and drinking water does help. It's a kind of like a short fix, like a short-term fix. It's not going to really help them in the long run, but sipping on water does help. A saliva substitute, and this is an example. This is called Biotine, and you may want to talk to their family members about this. And I've got a slide coming here in a minute about how much it costs and stuff, and it's pretty inexpensive, I mean, for the help that it gives them and the relief. And it comes with a mouthwash, a toothpaste, and a gel. And they can put the gel inside their cheeks and stuff, and it really, I give this to my patients, my older patients that are on a lot of medications like candy. And I'm handing it out to everybody because it works so well. And it's like a saliva substitute. It's not going to make them produce more saliva, but it does help with the discomfort of the mouth being dry. It kind of coats and lubricates the tongue and the cheeks and the lips. And then they can get a prescription called pilocarpine, and they get it through their doctor, and it stimulates salivary function. So, but these are just some, pretty much from here up, it's pretty much short-term relief, but it does help. And this is what I was showing you. This is the Biotine, and you can recommend this to some of their family members if they want to look into buying it. The toothpaste dry mouth protections, about $5.32. The mouthwash is about $6.78. And the gum's about $2.39. And then the liquid is about $7.99. And then the oral spray is about $6.50. So I mean, it's not like real cheap, but it really is helpful, and it lasts a pretty good amount of time. I mean, it usually provides relief for at least a few hours, and I know a lot of patients will put it on in the morning, and then they'll put a little bit extra on at night, because at night is usually when xerostomia is the worst, because a lot of times older patients will breathe through their mouth, and they'll wake up and just be in a lot of discomfort from where they don't have, normal salivary gland function anyway, and they breathe through their mouth all night, and they're just really uncomfortable. But this is just something that you may want to recommend. It's called Biotine. And I'll leave this here with Candace in case you guys want to look at it, or maybe give it a try on somebody. I think Rachel's turn.
Dentures still accumulate food, debris, and hardened plaque, which we call calculus, on their denture, just like natural teeth. So it's very important that their dentures are cleaned probably about twice a day. So when you're providing that, you can take it out because they know it works and it's just a little bit more comfortable. So what you want to do after it's removed, you just want to make sure to rinse it off just in case to get rid of excess saliva, any food debris that's on there. So there's two types of cleanings that we're going to talk about: cleaning by immersion and then cleaning by using a denture brush. And this one is cleaning by immersion. It's just taking the denture and soaking it into some type of detergent, which is usually done at night or can be used like right after they eat to kind of get off any bacteria, any food debris that remains on the denture. So what you want to do is just place the denture into a plastic container that is filled with the immersion solvent, and you just follow the instructions on whatever brand of solution you're using, and you just leave it in there for as long as it says, and then remove it, rinse it off, give it back. Kind of simple. Just kind of a good thing to do at night, especially because it can soak overnight and remove all of that bacteria. And then cleaning by brushing is using a denture brush, actually taking the denture out, cleaning it by hand yourself, giving it back. You don't want to use any abrasive agents like toothpaste, because what toothpaste can do over time is wear the like these part of the dentures that actually kind of holds it in there. It can just wear it off over time and it'll scratch it. So what happens is you're actually making more indentions into the denture where the bacteria can get trapped, and it's going to be even harder to get out. So you definitely want to make sure you use water or some type of soap or a cleaning agent. And a good quality denture brush, kind of like these, that have just a normal, looks like just a white brush on this end and a paper brush on this end to make sure you get those harder to-inch spaces. So when you're cleaning by brushing, one thing you definitely want to make sure you do, if you're cleaning in a sink, you want to lay a towel or a paper towel at the bottom of the sink, because what can happen if you drop it, it can shatter, and there goes some denture. And when you're holding on, and I don't, obviously have a denture, I just have my knife on, which is kind of hard to show you, but whenever you're holding it, you just want to make sure you hold it firmly as to not drop it, but you don't want to squeeze it, because as the denture gets towards the back, it's kind of going to get a little thinner in these edges, and if you squeeze it, you could actually snap it in two. So what you want to do, you want to rinse it off, get all the debris, any loose food that's on there. And you want to do this with warm water, and then just use water or apply your soap or whatever detergent you're using. And you just want to scrub it. sure that you get all the teeth and everything. And like I said, this one is good to get in those hard to reach places. Just make sure that you get all of the denture, not just the teeth on the denture, but make sure that you get every little indention and everything, especially in indentions, because that's where the bacteria is going to hide the most. And then whenever you're finished, you just want to kind of rinse it all off. Make sure that it's clean, because sometimes those detergents don't taste very good. And make sure not to leave any of that in here. So like I said, you want to kind of make sure, even if it's just rinsing them off and lightly brushing them, just do that several times a day. Make sure all of that bacteria is removed. And after eating and before bedtime is probably the most important. And then you can put them in immersion overnight to help get rid of the bacteria. For the patients that do still have their natural teeth, this is called the Bass method of brushing. And I know it's a little bit harder to brush other people's teeth than it is your own, because it's just kind of foreign. But what you want to do is you want to make sure to place the toothbrush at a 45-degree angle, just to make sure that those bristles get underneath the tissue. And there's a picture here that you can probably see better. But you just want to move all the way around the arc in tiny little circles, making sure that those bristles stay adapted to the top part of the tooth, kind of underneath the tissue there. Same thing on the back, tilt at a 45-degree angle, make sure those bristles kind of get underneath that tissue, because the bacteria does get underneath there. You have about 1 to 2 millimeters of loose tissue where the bacteria will kind of hide underneath there, and that can cause gingivitis. It can progress to worse things. So like I said, just little rounds of and then after you're finished with the entire arc front and back, you want to get the occlusal surfaces, like the chewing surfaces of the teeth, and just place the toothbrush on there, just scrub back and forth, just like that, every surface. And then for the inside surfaces of these front teeth, if you can see here at all, I don't know if you can really see on my model, but if you keep the toothbrush horizontal, what's going to happen is those bristles aren't going to get those teeth out. So what you want to do is you want to flip the toothbrush up vertically and sweep forward on the back surfaces of all of those teeth. And that'll help remove anything that you could be missing or they could be missing there if you're helping them, or even if you wanted to tell their caregiver, you know, how they needed to help them with this. And then also you want to make sure to brush the tongue. The tongue harbors a ton of bacteria. So what you want to do with that, and my model obviously doesn't have a tongue, but we'll just pretend. Instead of scrubbing back and forth, which is what I know whenever I teach my patients brushing instructions, they tell me, you know, to brush their tongue just back and forth. And what that actually does is just kind of distributes the bacteria everywhere else on the tongue and actually getting it off. So what you want to do is just sweep everything forward, rinse, sweep forward, rinse, just a couple of times, and that just kind of sweeps all the bacteria forward instead of making it go everywhere else. And this is just instruction on flossing, and I don't actually have a floss with me, but this is a good illustration of what you should do. A good amount of floss is about a shoulder to shoulder length. A floss, the best way to do is to wrap it around your middle fingers and grasp onto the floss with your index and your thumb. And you'll use about a 1 inch for each tooth, and you'll kind of want to have a new piece every time you go to each tooth. And what you want to do is you want to wiggle it in very gently. You don't want to snap it in, because snapping it in can irritate the gingiva and can cause recession. So then once you wiggle it in, you want to make a C shape around the tooth, and you can see that here, and just kind of move up and down gently. Take it out, wiggle, go in between the other two, C shape, up and down, back and forth. You want to just do that several times and be sure, like I said, to switch to a new piece of floss every time you move from one tooth to the other. And you'll just repeat that all the way around. Does anyone have any questions about any of this, or is this something clear? Rachel's going to talk to you about hand guns.
is actually part of our normal floral in our mouth, and this is very common in patients who wear dentures. Patients who are most susceptible to getting oral candidiasis are people that are on antibiotic therapies, cancer chemotherapies, corticosteroid therapies, dentures, diabetes, and patients with xerostomia. We all have a normal oral microflora in our mouth that contains natural bacteria that can be found. When a patient is on antibiotics, this natural microflora in our mouth is disrupted, so Candida albicans can actually come in and inhabit in the oral cavity. And they manifest in many areas of the mouth, but it's most commonly seen on the tongue and the back of the throat. It can even stretch down to the esophagus and get in the lungs and the kidneys. And this presents most commonly as a white, curd-like substance on the mouth, wherever it's manifesting, like on the tongue or the back of the throat. Candidiasis and diabetes are directly linked. A patient with diabetes has a higher chance of getting candidiasis. This is most commonly seen in a patient with uncontrolled diabetes. The xerostomia patient is also at risk for getting oral candidiasis. A rare fungal infection that can be found linked to diabetes is mucormycosis, and actually inhabits in, along with the Candida albicans, it can affect the nasal cavity, the maxillary sinus, and the hard palate. It presents as a proliferating mass in the maxilla, and it can damage the oral cavity. Candidiasis and diabetes, when the diabetes is uncontrolled, you have a result in a loss of blood sugar, which increases the patient to get Candida albicans. Some easy management methods: be aware of the antibiotic usage of the diabetic patient. It's also important for oral hygiene instruction, keeping that calculus and plaque down, and then adequate nutrition is linked to diabetes and getting the oral candidiasis. There are 4 types of oral candidiasis: pseudomembranous, erythematous, denture stomatitis, chronic hyperplastic, and angular cheilitis. And we're going to go through all of these. I'm going to show you some pictures. This is pseudomembranous. You can see like the white right here. It can actually be scraped off, and underneath it, the oral tissue will be very, very red. The patient can sometimes complain of a burning sensation or a metallic taste in the mouth. Erythematous is just going to present as very fiery red mucosa. It's often very painful. It can be in a localized area, which could be like one specific area, or it can be all over the mouth, such as the hard palate, soft palate, and the tongue. Denture stomatitis, this is one that we really want to pay attention to, since a lot of the patients here do have dentures. This is the most common type of candidiasis. It's also known as chronic atrophic candidiasis. Once the patient removes their denture, such as the primary caregiver or a dental hygienist or a dentist, is when they find this condition. It's most commonly found on the palate of the maxilla. There's no symptoms to this, but like I said, it's mostly found by you all who are doing the oral hygiene care. Like the chronic hypertension, there's no symptoms of the infection. The diagnosis is confirmed with a reaction to antifungal medication. Sometimes they can do they can scrape off the infection and send it to a lab, but in this case, for the chronic hyperplastic, they usually just treat it. But if they treat it and they suspect that they have chronic hyperplastic and it does not heal, they will want to remove the lesion and have it sent off to be tested. Angular cheilitis is very common in the geriatric patient. It's like redness on the commissures of the lips where the top and bottom lip meet. It's most commonly caused by Candida albicans. It can also be caused by a nutritional deficiency in vitamin B2, which is riboflavin. So you want to make sure that they're getting enough vitamins in their diet to prevent this condition, and there's no pain associated with angular cheilitis. Another common condition found with Candida albicans is median rhomboid glossitis. In some cases that patients have this, it has been linked to Candida albicans. It appears as a red rhombus-shaped flat raised area on the midline of the posterior part of the tongue. These lesions can be treated with antifungal medications, and there's no signs of this. or no, sorry, excuse me, there's no symptoms of this in the patient. You'll just see it on the tongue. Diagnosis consists of positive culture is needed to confirm the presence of Candida albicans. Like I said earlier, usually when a patient is suspected to have oral candidiasis, they're just treated for the condition, and the antifungal medications will clear it up. And the surface of the lesion is scraped off and with a tongue blade, and it's smeared onto a glass slide. It's sent to a laboratory, and it's tested for the presence of Candida albicans. And like I said before, sometimes they just go ahead and treat it, and the antifungal medications will clear it up. Some treatments are topical milestane and systemic fluconazole, are known as diflucan. So these are our references for all of our information that we presented to you today. We greatly appreciate your time and attention and listening to what we have to say. Is there any questions or any comments anybody has? No? Okay, well, like we said, we greatly appreciate it.